about the role of the knee.
Thanks, Ben. So we're going to talk about, I've been charged with version abnormalities, also known as the other white meat. So not just about the hip, we have to talk about knee considerations as well and be mindful of presentation. My disclosures on the website, nothing relevant. So considerations for femoral derotation, femoral version issues. The axial position of the femur affects obviously not only the hip, but also the patellofemoral joint, the tibiofemoral joint, the ankle, and subtalar joint. And any consideration for changes in one has to be balanced with consideration of how that's going to affect downstream components. So starting out, what is abnormal? And the short answer is we don't really know. Tibial torsion measurements considered in Caucasians, probably about 35, 40 degrees upper limits of normal, including standard deviations above normal. Keeping in mind that within a Caucasian population, there have been studies looking at Indian population, for instance. Indian subcontinent has shown lower tibial version on average, same thing with Far East as well, maybe lower compared to the Caucasians. And femoral torsion, I think there's been more of a acceptance of 25 degrees as maybe an upper limit of normal. What the lower limit of normal is it 0, is it -5, is it 10 degrees? I think the topic is still debated and ongoing and how that affects our treatment options. So it's also important to consider that the prioritization of a joint in the setting of a maltorsion is different in different patients. And what do I mean by that is that, some patients that have femoral retroversion may prioritize their foot progression angle at the expense of their hip and swing their leg in. Other patients we find may do the opposite. They may prioritize lack of impingement and walk with an out-toeing gait, for instance, in the setting of femoral retroversion. And all of those things have both upstream and downstream components, depending upon how that individual patient is prioritizing their individual pain and walking manner. So what are the downstream considerations with both extremes? So with femoral anteversion, we think about dynamic internal rotation of the hip. We talk about think about the medialized trochlea, which gives a relative lateral translation of the patella that causes lateral foreshift with increased lateral patellar tilt, relative increased lateral tibial tubercle trochlear groove distance, and a valgus knee position. With an ankle, in-toeing gait, with an anterolateral joint force across the ankle, but keep in mind there have been studies looking at foot progression angle in the setting of femoral anteversion, and while an in-toeing gait is positively predictive of femoral anteversion, a normal foot progression angle can also have femoral anteversion at a sometimes equally high rate. With femoral retroversion, we see the opposite dynamic external rotation of the hip. We see a lateralized trochlea with relative medial translation of the patella, which can cause medial foreshift, medial patellar facet overload, as well as varus knee position with MCL overload. And at the ankle, we see now out-toeing gait, and in extremes, what happens with that is that the ankle is no longer in the normal plane of motion, and patients can rely on their subtalar joint to work as their primary ankle dorsiflexion, plantar flexion moment, which can cause posterior tib tendon insufficiency. So we see femoral anteversion. I think if you have focus where you just have the MRI, you can miss things like tetratorsional malalignment, previously called miserable malalignment syndrome, where you have both femoral anteversion, which would lead to an in-toeing gait, but tibial external rotation, and the knee is caught in the middle. And addressing one in the absence of the other sometimes can work, sometimes may be an issue. So it's important to consider whenever you have these patients that we're asking about other symptoms, that we're looking at them not only as they walk down, but get them into shorts, see how their patella is moving, see how their ankle is moving, see how their foot's moving. And so we're measuring tibial maltorsion. There are a couple different ways to do this. Relations between the transcondylar axis, transmalleolar axis, external tibial torsion can cause, again, patellofemoral issues with patellar instability is the most common thing because of that increased tibial tubercle trochlear groove distance and patellar tilt. So clinical considerations for me when patients come in with hip and or knee problems that we're looking at femoral anteversion is, what else is going on there? Do they have history of patellar dislocations? Have they had prior surgery, right? They may have been to, if you're not doing the knee surgeries yourself, to one of your knee partners or elsewhere where they have had previous patellar instability surgery to address their focal patellar instability, which may have been a proper treatment for the knee, but may have missed femoral torsion issues or tibial torsion issues. So on the clinical evaluation, what's normal variability of pathological deformity, also keeping in mind things like Baton score. So we're looking at the internal external hip rotation, both in flexion and extension, the thigh-foot axis, transmalleolar axis, and the heel bisector angle to try to get a sense of where is this abnormality coming from. Is it the femur, is it the tibia, is it the foot, and a combination thereof, and also a functional assessment during their gait, looking at their foot progression angle, keeping in mind, again, that with foot progression angles that are normal does not necessarily obviate the problem of a torsional malalignment. On radiographic evaluation, again, for me, it's standing x-rays, bilateral, hip to ankle, so you have a coronal alignment perspective as well as CT version study, which I consider to be the gold standard, looking at the axis between the femoral neck, the posterior condyles, the posterior border of the tibia, and then the transmalleolar axis. That one is not there, but one thing to be of note here is that when you correct, or if you correct, the axial malalignment of the femur, that will also change your TTTG. And so if patients have both hip and knee pathology, I think it's important to consider how the effect of one is going to change the other. Is that going to set you up for success in many cases, or is that going to set you up for problems? Example of that would be someone who may have already had a tibial tubercle osteotomy to treat patellar issues, missing the femoral issues, come into your office with hip issues, and then if you do a retroverting osteotomy, are you going to over-medialize their tibial tubercle relatively, or over-medialize their trochlea relative to their tibial tubercle, and that can cause potential issues. So something to keep in mind. So just two illustrative case examples. This is a 21-year-old male, bilateral foot pain, bilateral medial-sided foot pain. Mother was a neurologist, interestingly, and watched this patient walk since childhood with difficulty, could never really jog or run. And he states that he has to walk with an out-to-home gait, normal foot progression angle causes pain, he's tried conservative measures, and otherwise no major significant issues. And if this will play, you can see that was his foot progression angle. Now, interestingly, he complained nothing of hip pain. His primary complaint after being referred from my foot and ankle partner was posterior tib tendon insufficiency, and that's what he had been treated for a number of years. Measurements showed limited internal rotation and normal issues, normal alignment on the tibia. So workup gets, again, coronal malalignment or axial alignment views to make sure there's no coronal malalignment. Torsion measurement showing significant femoral retroversion, minus 21, minus 18 on both sides with normal tibial version, and bilateral labral tears with impingement pain. This is how I do my derotational osteotomies. He had a hip scope. Looks like we're missing it. And derotational osteotomies over a nail bilaterally, and ultimately did well. He continued to have issues with his foot, right? So he needed orthotics chronically and is considering flat foot reconstruction at this point. He's about 4 years out from surgery. This case, sorry, it is here. So this is how I do a derotational osteotomy. Put the nail in, complete the osteotomy after sliding the nail down, Shan's pins to derotate and correct the femur. So skipping to the next case, this is a 27-year-old female, bilateral knee pain, and initially came to my office complaining for 2 years of mild hip pain, but that was intermittent, sporadic, and then when questioned really had 10 years of chronic knee pain, but she had dismissed that because ultimately she had been to multiple orthopedists, she'd had MRIs, she'd had workups there, and everything looked normal. Past medical history of lupus on methotrexate, Bateman score of 5, mild in towing gait, hypermobility of the patella, positive J sign, and leg length and a coronal malalignment showed no significant issues. The torsional measurements, however, showed that her femoral version was 21 degrees, 22 degrees, but her tibial version was 43 and 45 degrees external bilaterally. So I would call this a variant of a tetratorsional malalignment with more mild femoral antitorsion and then more significant femoral tibial external rotation. And ultimately, her issue was her trying to balance out between her knee and her hip. So decision making here, she also had a elevated TTTG with some patellar instability. So ultimately, the conversation that we had and what we ended up doing was a tibial derotation at a supratubercle level. So you can derotate the tibia and incorporate the tibial tubercle in the distal fragment. That allows you to change not only the rotation of the tibia, but also medialize the tibial tubercle at the same time. We had the benefit of showing this case in that we had computer planning for the second knee. The first knee was not commercially available. So here we have the knee before it's fixed, and you can see significant lateral mobility of the patella with flexion. This is the corrected knee with a much more stable patella. This was right before we did the left side. So this is what she ended up having, bilateral tibial derotations. We talked about the femur given what's going to happen, because as you internally rotate the tibia, if she starts externally rotating her foot, she may be causing her hip to now become unstable, right? She's got a femoral anteversion of 21 degrees. Is that going to dynamically push her into femoral instability? That was a conversation we had with the patient. She opted not to do anything for the femur at the initial setting, and ultimately has done very well and has been 6 years out and running without any residual hip or knee pain. So as we think about this, right, there has been ongoing conversation about the relevant use of femoral derotational osteotomies, with studies showing both improvements, others questioning its use. But I think in the setting of ongoing issues, it's something that we all, I think, agree here that we have to consider. But as we consider it, you also have to consider the tibia. So in my hands, I think about, is there ipsilateral knee pain? Is there evidence of squinting patella where the feet are facing forward but the patella is facing more medial? Is there normal foot progression angle with abnormal femoral torsion on examination, abnormal thigh-foot angles, or a history of prior patellar malalignment surgeries? Those all call into question, if we're evaluating the femur, I think we have to evaluate the tibia so that we know when we change one what we're going to change on the other side. Thanks very much. Appreciate it.
Thank you.